Acute Management of Pelvic Ring Injuries. This is from the OTA Core Curriculum Resident Lecture Series version 5. Slides are by Dr. James Black, and I'm Saqib Rahman narrating. And in the first video, we talked a lot about, a little bit about anatomy, a lot about classification, mostly young Burgess, but I also described tile to you. We talked about other associated injuries like GU injuries, and now let's talk more about hemorrhage. So, control of pelvic bleeding is integral in the management of trauma patients with pelvic fracture. It used to be the classic trauma imaging series when a patient came into the trauma bay was chest, C-spine, and pelvic x-rays. It was a routine radiograph that you would get on everybody because if you had a pelvic fracture, this is a potential source of massive blood loss. So that still remains to be the case. Imaging has changed and protocols have changed somewhat, and a lot of times we're seeing a lot of CT scans done, and the pelvis is imaged on the CT scan. So a lot of times routine pelvis x-rays are not being obtained anymore, but this just goes to show that it is an important source of bleeding. So there's arterial as well as venous and bony structures at risk for hemorrhage within the pelvis. The patients who have systolic blood pressure less than 90 on presentation and early transfusion requirements do have increased mortality, as we mentioned in the last video. So in young Burgess classification, some of the earlier papers discussed how much hemorrhage you get with different fracture types. And it so happens that the anterior posterior compression, especially the APC type 3, in particular, has by far the highest transfusion requirements. The vertical shear is a significant amount as well. So when you have sort of lateral compression and the pelvis closes down, you actually have a decrease in pelvic volume and less bleeding, as opposed to the APC, where you have an increase in pelvic volume, lack of containment, and increased bleeding. But severe hemorrhage can occur in any pattern. So, if pelvic, expansion and sort of the APC types are very difficult for bleeding, then how do we deal with that? Well, containment, closing down the volume, using a sheet, using a binder, using external fixation, sometimes a C-clamp, and even internal fixation. Other techniques are dealing with the arterial bleeding with angiography and embolization. Another technique, which is also effective for the venous bleeding, is laparotomy with pelvic packing. Frequently, it's preperitoneal pelvic packing. So, when you think about containment, again, this helps to allow for the tamponade effect by closing down the pelvic volume, stabilizing the injury to allow clots to form, and this can be a very, especially for an APC injury, reducing the widening can really be helpful. Pelvic binders are these commercially available things that are very easily put on in the field, for example. Most importantly, they have to be properly positioned. You have to center them on the greater trochanter. So you don't center them on the lower abdomen. Otherwise, they will ride up and they really don't help control. You have to center them at the greater trochanter. And you could have something like this APC type 2 injury that could really close down nicely with a pelvic binder. I can kind of see what I believe is maybe the pelvic binder. I see these shadows here. I'm not sure if that represents the binder, but this has been closed down with external methods. Now, a sheet should be available anywhere. A binder is a commercially available product. A sheet should be in any hospital, right? And this is just a nice technique paper referenced below that literally just shows what a good sheeting technique would be. And you can notice, again, centered on the greater trochanter, and you can see wide, application, and using clamps. So not taking the sheet and just like tying a knot, which then tends to be a narrow sort of rope, but really sort of using a wide approach and then clamping it down. So you can look up these links for more resources. When you use a sheet, you can then also cut holes in the sheet to allow access for external fixation, for interventional radiology as well. So if you need to work through these portals, you're able to do that here. Here you can see an example of pelvic anti-shock sheet binder, and you can see the sheet being clamped on the right-hand side, and you get really nice closure of the pelvis. If you have binders or sheets on for a very long period of time, for days, you can potentially get some skin issues, so just be mindful of that. You can see there's case reports of this, but sometimes you have to be on longer than you like. Another thing is to tape the lower extremities. This is something you can do in the operating room when you're going to fix a pelvis or fix a pelvis, but the patient's up in the unit after admission and you put a binder on and they keep abducting their hips and the knees externally rotate and the binder then gets driven proximally. Sometimes you can just do this as well. Just wrap the knees or ankles and tape if necessary, and that can also help. You can see here in the fluoroscopic images how much reduction you can get. So external fixation, right? These can be placed at the AIIS, ASIS. There's also a C-clamp. These can be resuscitative, augmentative, or definitive in some patients. All options can be very effective when the posterior ring is intact. AIIS placement, which is shown here, these are AIIS pins, are very helpful with vertically and rotational unstable patterns. They allow a little bit easier access to the pelvis and abdomen than the ASIS pins, or I should say iliac crest pins. And they're a little bit better tolerated by patients. Here is a example of the technique in the ASIS. You're usually going into the iliac crest rather than into the ASIS itself, and you use the thickened portion of the iliac crest, which is the gluteus medius pillar, and you kind of aim them towards the hip joint, and it's described in some detail here. Just keep in mind that with poor trajectory, these can kind of cut out. So you want to be between the inner and outer tables. And sometimes if you're good imaging, you can kind of see where that pin is going. So it's a nice technique. You localize with a K-wire. You can then pre-drill the outer cortex, and then you can sort of send the pin in between the tables, allowing it to sort of find its way. Now, the AIIS technique, you really do need to do with imaging, whereas the crest pins, sometimes you can do with minimal imaging, and they've been done with no imaging in experienced hands. So you need to have multiple views as described here. You can localize here. You have to make sure you avoid the hip joint and you avoid the greater sciatic notch, because you don't want to breach that inferiorly and get into superior gluteal artery bleeding, for example. So lots of imaging to get your start point, and then to confirm that you're safely positioned. You're kind of aiming at the PSIS through the sciatic buttress. So here's an example. You're showing a K-wire with this obturator outlet view, and then drilling and then placing the pin on that view. Here you can see in your iliac oblique view, you can see you're trying to aim above the greater sciatic notch here. On the obturator inlet view, you can see you're aiming at that PSIS. Here are your images on inlet and outlet views, demonstrating an X-fix actually with the large distractor in place, you can see here. And there's technique videos in this description if you want to go to otaonline.org. So C-clamp is another technique that if it's available to you and you're comfortable with it, this can really help to control the posterior pelvic ring. As shown here, you do have to be very careful with these. You don't sort of inadvertently go through the greater sciatic notch, and that can be a very severe iatrogenic injury, but it's a nice technique if you're comfortable with it. Here's an example of that C-clamp. You can see being used to control the posterior pelvic ring. Pelvic packing. This can be done with an X-lap. Patients going to the operating room, needs an X-lap, but there's also a pelvic ring injury. So you can also do pelvic packing, preperitoneal pelvic packing. And if you're going to do this, you often have to do an X-fix at the same time because you need to have some type of external stability. And if there's an X-lap and there's an incision down there, oftentimes sheets and binders can't really be used as easily. And there's a sort of technique where to pack that tends to be effective. So if you are very comfortable and set up in your facility to do SI screws and experienced hands, you can close these down pretty quickly with SI screws. So here's an example, patient with unstable pelvic fracture and hemorrhage. They've put a sheet and binder on and gotten some reduction, but not quite enough. It's improved on the right, but then you can see they decide to go ahead with an iliosacral screw, or two in this case, and are able to close that down significantly. Even if you don't like your reduction as being as perfect as possible, this can be sort of a temporary technique, and you can come back later and revise the screws when you have a more stable patient, for example, but you can see how this can really close things down. Angiography is somewhat institution dependent, meaning some places have very ready access to very experienced angiography teams who can come in to help with arterial bleeding. Other institutions, maybe not as much. Historically, its effectiveness has been questioned because it's thought that pelvic bleeding is more commonly venous, but there is evidence to support its use. And a lot of times when you get a CT scan and you see this extravasation blush, so to speak, at many centers they'll proceed with arteriography. Now, this can also be done potentially in a hybrid suite where you have the opportunity to do multiple techniques, both with sort of interventional radiology as well as surgical techniques like packing or external fixation. So here you can see left superior gluteal artery disruptions. You can have significant bleeding from this. And then post-embolization, you can see they've coiled this. And so this can be an effective technique for arterial bleeding. So if you have a hypotensive patient with a stable fracture pattern, we look for other sources of hemorrhage and proceed to laparotomy. But if you have a hypotensive, unstable pattern, transient responder after binder placement, extrav, then you can go to angio. So this is one way to think about it. And here's a protocol if you want to pause the video and take a look that might make sense or work in your center to incorporate these methods. So multidisciplinary approach at a level 1 trauma center coordinated by trauma surgeons and orthopedic traumatologists has resulted in improved survival, with reduced early deaths from exsanguination and late deaths from multiple organ failure. So understand the fracture patterns. Going back to our first video, classifications, combine that knowledge of the fracture, the condition, and exam, and available resources to determine next steps. Be prepared to intervene to stop hemorrhage. And management of the hemodynamically unstable pelvic ring patient. It's really a multidisciplinary event. And orthopedics is going to get involved. I mean, if you're a resident at a trauma center, these could be very sick patients. And this could be the one time where, trauma really does need your help to help a patient from preventing from bleeding out. And you have to be prepared to do something. A lot of times that's going to be helping close down the pelvis, understanding where the binders go, making sure they don't take the binder or sheet off when they go to interventional radiology, etc. And you can be a really integral part of that team in the acute management phase. Thank you.